we will be joined by Mr. GARASSUS as we go along. It's always an honor for me to open the first roundtable at Chamonix. The theme is healthcare or health areas. It's not a new question, but it particularly resonates since we launched what we call the Great Debate in France. And this great debate, led by the President Macron, we tried to respond to this recurring demand where people said, I want to have access to a healthcare professional near my home and in my territory. But what territory are people referring to? Is it an economic area, an administrative district, geographic area, a political area? The problem in France is that these different territories are not always identical. And France has this genius of piling up structures, decision-making bodies and financing bodies and political decision-making bodies. I won't come back to this situation we have in France with the commune, which is the municipality, up to the département, all of the different layers all the way up to Europe. But how can we make sense of and give some more coherence to these territories? In roundtables, we often have the experts express themselves, and then we often give people the floor at the end. Well, we will start first here. We'll do the opposite. So, hello, Catherine CERISEY. Many decisions have been taken at the national level for healthcare, but concretely, this leads to aberrations at the local level. Do you have an example of this type of national decision from the top down, which ended up with negative results? Well, good morning, everyone. Thank you, Mr. Valencien, for having invited me. Thank you for introducing me as a person from the field and not an expert patient. And I don't think an expert patient is the proper term. A few years ago, we had a citizens' consultation about what we call the ambulatory evolution in oncology. And this was a national decision, but no one had taken into account the organizational aspects. And we had two associations that consulted the French citizens about this problem. We went to visit 3 different regions around Paris, north of Paris, and in Auvergne-Rhône-Alpes. We realized when we talked to people that there were some real inconsistencies. Let me give you an example. Everyone knows that we talk a lot about consumerism, medical consumerism. We talk about the emergency services. And you all know that on Saturday evening, people say, oh, when people are bored on Saturday evening, they just go to the emergency ward. And obviously, that's not true. When you have cancer and you are being treated in your home, which is more and more frequent, we also know that on Saturday evening at 2 a.m., if there are adverse effects that occur, you start to panic and you don't know where to go, and you call the emergency telephone number and they tell you to go to the emergency ward. So sometimes people aren't that far away. But in real life, there are beautiful mountains, such as the ones you see here, and to go to the hospital, you have to go over a mountain pass sometimes. And instead of taking it a half hour, it takes you an hour and a half to reach the nearest emergency ward. So you have patients that are not, who feel abandoned. They do feel abandoned. And this change to ambulatory care, which was a good theory upstream, it wasn't really well organized downstream in the field. So the problem was the actual concrete application of a decision taken upstream. So Gisèle Gravier, you are a visiting nurse. You're the coordinator of the CPTS, which means professional community, a territorial professional healthcare community. So this is healthcare professionals and not just doctors who get organized together to improve the coordination and the care path. So before you had a legal structure, you set up ahead of time. So you're real pioneers. Can you give us an illustration of the usefulness in France of this territorial healthcare professional community? Good morning, everyone. The usefulness is that it helped structure our healthcare territory. Our CPTS started well before the reforms, in our healthcare system. In 2012, a GP locally in our area realized that he was working alone, and it was useless. Obviously, it was useful, but it wasn't sufficient. And so it was better to coordinate with the other healthcare professionals and extend the work to the entire territory, to really have all of the local healthcare stakeholders benefit. Rapidly, we realized that he had to bring around him not only the liberal healthcare professionals, but also the local hospitals, also the institutional partners, working with the French health insurance authorities. So please avoid these abbreviations. So the regional health authority, for example. So yes, all of this gradually became structured, and we were able to, Marisol Touraine, when she was the minister, she contacted us because she wanted to experiment her own program that was designed to help the elderly who were losing independence. So she chose our territory as a pilot project for her program, and we were able to test this in real conditions, test our capacities to get organized, to work together, and to carry out a common project. Thank you. Olivier OBRECHT. Now we will be talking about the regional health centers. When we were preparing this roundtable, you told me that for you, these agencies should act as integrators. Your role is to distribute the needs in the territory, in the field. So that's the theme of this roundtable. We know that one of the main problems is this interruption between the hospital and ambulatory care. Between cities, sometimes, there are also interruptions. So this is why these healthcare contracts are so useful that you wanted to set up in Burgundy. Could you explain a bit more about how these framework healthcare contracts work? Yes, good morning, everybody. I think what was just said by the previous speakers, everyone's saying the same thing, along with Guy's introductory speech. The right scale is the scale that has meaning for people. The right level should start with concrete needs. And then the solutions will be immediately perceivable. In the region that I work in, Burgundy, we chose to distribute the entire region into 33 districts, which are, we call them, we have an acronym for them, but they're little local areas where there's a logic around the local authorities with the health insurance authorities and the county authorities. So beyond what the texts actually have planned for, we tried to coordinate even further. Let me give you some examples. Just one example, then. Okay. That's tough to give you just one example, but I'll take the example of what we call the ephemeral doctor's office. We had a lot of doctors who were retiring or leaving, and so we had a real gap in our healthcare offer. So everyone sat around the table, the doctors, society, all of the healthcare professionals, and the regional authorities, and we rolled back our sleeves, and we looked at the texts, the legal texts, and the town hall renovated a space, a facility. The retired doctors were contacted by the health insurance authorities. We organized the transport for the doctors and guaranteed their resources if the system didn't work. And we had actually 10 doctors who volunteered within a radius of 30 kilometers to do what we call ephemeral doctor's visits. So we have a very concrete example here where we were able to give a temporary answer. We do hope that we will be able to create a more sustainable health center in the future. But we see that when each of the stakeholders really gives his best and decides to work together instead of working against each other, this gives good results which are even temporary but quite efficient. Thank you for this example. Paul GARASSUS. So one of the recurrent problems in France is the missing link in the chain between an isolated practitioner and the healthcare centers with whom he could work. So when we look at other countries, we see that these links are not always missing. And I would like you to tell us more about medical centers such as the ones you have in Germany which really are a link between healthcare institutions and solitary doctors. Well, we took the example when we were preparing this session to say that we see what a territorial healthcare offer is when it's focused on the hospital. But then when you look at the link with the private doctors, often there's a real, not only a geographical link that's missing, but also skills are missing. And in Germany, they've set up what they call healthcare centers, proximity healthcare centers, which are actually satellites between the expert hospitals, which bring together the experts, and private doctors. So what is the advantage of this? Well, first of all, you can create your independent legal status. You can be private, public. Practitioners can create their own center, and the practitioners who are exercising can also work in the hospital, so the diagnosis and the follow-up can be carried out by the same doctor. And among the 16 Länder in Germany, we're often talking about a regional European healthcare systems. So it's in Germany, we certainly have a regional organization already. So the European reform should fit right in with that. So this reform came from the Länder in the east of Germany. So there was a lack of resources. They were lacking healthcare. And so what did they do? They did a copy and paste, and they said these polyclinics were disappearing, and yet they were a useful link. So developing a territorial connected healthcare offer. It exists in France, but what's interesting is that there were already 2,000 of these centers in Germany and only 500 in France of these multidisciplinary centers. So the idea is to really to look at Germany for a good example of this coherence in the territory. Yes, so in France, we're going out of the administrative structures. In France, it's quite bureaucratic. You have to meet a certain number of criteria. Apparently in Germany, it's more fluid and simpler. Well, let me reassure you, I've been going around Europe for years, and everyone complains about their administration. So don't worry. The regulations are there for governance and to regulate things. But what is really interesting is that you need to break down the barriers. The initiative could be the local doctors, it could be the specialists, but also the hospitals. Let me take an example in my area of responsibility. The Helios Group, which is the first private hospital group in Germany, they have over 100 centers of this type. They deliberately took this opportunity to improve their own healthcare offer and to offer more territorial healthcare. Françoise GROSSETETE, you're a former member of the European Parliament. On healthcare questions, you're particularly well experienced. We know that we can go all the way up to Europe, and I want you to give us an example of an action that can only be conceived of at the European scale. Well, when we heard, first of all, Guy Valencian this morning, and then the representative of the European Commission, you can understand that there are a lot of things that should normally be handled at the European level. And I'm always very happy to hear Guy Valencian talking about this Europe of healthcare. I think it's indispensable to build this European healthcare. Some examples. When we talk about fighting pandemics, when we talk about the need to harmonize and vaccination policies, for example, when we talk about passing laws concerning drugs, obviously Europe is relevant, but I have an even more relevant example that we referred to previously. The case of rare diseases with the European Reference Network for rare diseases. It's inconceivable that we cannot work at the European level. That is just absolutely indispensable. But this means that we must completely rethink the governance of our healthcare policies, and we must accept to be very modest and humble, to consider that other countries perhaps have different visions in the European Union, that there are best practices elsewhere, that perhaps we don't always have the best practices in our own country. This all requires a real open-minded approach that's political and intellectual, and quite a specific approach. Thank you. So you used an important word, which is humility. And I think in France, sometimes in our structures, professional structures, we lack humility. And we think that what we're doing in France is the best and no one can do better. That's interesting to see what's happening with our neighbors. And perhaps we could take inspiration. The idea is not necessarily to copy. I think we have a very Franco-French habit, which is saying copying is not good. And maybe that comes from our education. The idea is not to copy, it's to adapt, to transform, to take inspiration from. And as you explained, France has this tendency to say, oh, things are better in France than elsewhere. Yes, we have a good example of this, and we talked about it earlier, the assessment of medical technologies for the clinical aspects. It's true that we really, the parliament that I belong to, the European Parliament, up until the recent European elections, had decided to vote this HTA, but there was a blockage from the member states. And so we'll see what will happen with the new European Parliament, with the new European councillors, the new European Council as well. But for me, there's a real necessity to move forward. But this means we must accept that others carry out these assessments and we take them into account. Certainly the representative of the European Commission explained that there are too many disparities still in our healthcare policies of the member states. But nevertheless, in France, even if we have a healthcare system that is quite well recognized everywhere, we need to accept that others have good reasons to assess in our place.
We will have a roundtable on digital issues after this one, but still, I'd like to have your opinion on how the digital in France could help harmonize our territories in the facts. So who wants to answer this question? Yes, I can answer. First of all, the digital is a tool. It's just a tool that helps us improve things. It is not the solution. Now we talk about 5G as a miracle, but we are very far from 5G. In fact, we will have immediate responses, that's fine, but in some territories in France, we don't even have 2G. It's really tough. I was in the region of Auvergne recently. There's nothing there. So this is a disaster. You cannot start talking about 5Gs when some regions in France are still not covered by any network or not even the 2G. We have medical deserts, and we have a commission last week which made a proposition. When you travel around Europe, you have portability, you have roaming, and you move from one operator to the next one. But in France, it doesn't happen like this. If we could have this between our operators, Orange, Bouygues, SFR, and so on, it would be much more simple. But it's not like this. And then you can say that Wi-Fi is great. It can help you when you're at home. But Wi-Fi is not that obvious. In some French territories, you have some regions without Wi-Fi. So where you don't have a mobile phone network, you don't have a Wi-Fi usually. We will have 6,000 Wi-Fi hotspots funded in Europe. I would like to know if this will be in Clermont-Ferrand, in the city center of Clermont-Ferrand, or it will be in the rural areas. Françoise, for 25 years, was a star in the European Parliament for health issues. So I wanted to say this to the public. She is the best person available to answer on all European issues. So congratulations. But you've got to remain humble. Yes, you've got to remain humble, but the truth is what I just said. Now, e-prescription. Lithuania, not one of the most developed countries. I work transversely, north-south, east-west. In Lithuania, e-prescription is about 100% of prescriptions. European Directive Patient Mobility, that should come in place very soon. In Lithuania, when they can prescribe something in Lithuania, but also in Finland, so they work in a transborder way. A very simple fact, 17 million Europeans live in a EC country which is not theirs. Many millions of students, European students, travel around the various European countries. We have talked to the European Commissioner saying that at present we are faced with the difficulty of interconnecting ministries of health in the interest of European patients, and we want to promote the DG Connect system with open doors. You are hospitals, we have the fundings, we want to fund you so as to open your doors. Mr. Garassus, yes, you can't talk about health or telehealth if you don't have the appropriate means. When you talk about e-health, you're not going to uniformize territories. The structure of the offer determine the answer that you may bring. However, our system is structured in 3 ways. First of all, we want to abolish distances for patients who are far away from any professional telemedicine, tele-expertise. Secondly, and this will be even more true in the future, we have non-planned care, and it is difficult to reach a competent professional who could reassure you or direct you to appropriate services. You have a telephone number now, the 15, but it's not enough. Third, the third added value is that you must promote rare expertise without having patients moving around. The aspect of patient mobility is very significant, especially in vast territories as ours. When you need experts in cardiology, dermatology, or mental health, you could use telemedicine, and this would be a major axis for progress. But when you are in the region of the Morvan in France, you need to have the appropriate networks. That's true. We mentioned local partnerships. I think that many local authorities, regional councils have put that issue on their agenda because it is an issue of global development for their territories. We want to stop the emptying of some rural territories now. But we are all aware that there's a lot of way ahead. Locally, we have witnessed wonderful initiatives. Now, in France, how can you move from the experimental stage to a vast deployment of services? How can you change scales? What are the conditions for success so as to reach a global coherence in France? I cannot speak in the name of professionals, but I think that you've got to accept that sharing of experience and this distribution of skills. You have the national scale, but we've got to give some leeway to the regional scale because that regional scale is fundamental. But the intermediary scales have to accept to transfer some skills to professionals of a different scale when necessary. Humility is key here again. It's not just about health professions. We've got to change our set of mind. In the service of the patient. That's the first objective. So this is indispensable. We are not going to move from a vertical organization directly to a strictly horizontal organization. We need a combination of both. We need some leadership. But I think we should have more flexibility at regional level. This is absolutely essential for this system to work better, and we've got to accept that sharing of skills and experiences. I think that you must start from the needs on the field, and you must co-build something. You talked about bringing all actors together, but you did not mention patients. Were they present? You did not mention them. I think that patients, citizens, users, no matter how you call them, they must sit around the table and we must co-build something. When you co-build, you can reach a coherent result, something that is in adequacy with the reality on the field. Now, we have to have a system that can be adaptable, and we have to support such a system. You cannot decide something and impose 100% digitalization without supporting people, supporting practitioners, patients. There is an issue of digital literacy, which has not been mentioned so far. And then we have to evaluate this. And if it doesn't work, we've got to be humble and say, we'll try in a different way. I think it's about exchanges, and it goes both ways. We cannot impose things from the top. Exactly. Hence, this question of evaluation. If you want to deploy something, you've got to first evaluate what is already in place. Did you evaluate what's in place? Who has evaluated? How? And what would be the next steps? When we started this professional community, we built a project, a health project, along a few lines. We had some indicators so as to evaluate the means that we had set up and to evaluate the results we had obtained, knowing that the results are not always easy to evaluate from one year to the next, because in terms of prevention, you cannot quantify the effect of a given campaign and its immediate effects. We were monitored by a monitoring committee. We did not have a steering committee because we wanted to remain flexible. Thankfully, this monitoring committee were made of representatives of the local health authorities, representatives of the local hospital, representatives of users, and many others. And this monitoring committee, fortunately, was very positively orientated. It gave us some ideas, and I forgot to name the URPS, the Regional Union of Independent Practitioners, who in the region, the center region of France, created an association. So this monitoring was carried out in that way. Up to now, we had some kind of freedom because we were funded by regional fundings without having a specific agreement. Now this is going to change because the National Health Insurance is going to sign a convention with the health professionals. So this will be a framework for us with objectives. We are working on indicators, and the question at present is who is deciding upon indicators? This is the very basic question. That's true. So as Mrs. CERISEY said, there are some exchanges between the work on the field. Health professionals are working on their indicators for the actions which are relevant to them, and this will be transferred on to the authorities. At a macro level, we have a risk evaluation system. We lack some metrology. So how are we going to measure things together? We may be not so well funded, but it's true for all of us. The latest evaluation by the Harris Group on practices in health for primary care. The title of the book is Flying Blinder. All of us are blind with respect to quality criteria and indicators. All this has been a collaborative work. In Brussels, we never organize a meeting on patient associations. Mr. OBRECHT, yes, we have this issue between the global and the regional. The central health authorities have to deal with regional health authorities and find a balance, and the local partners have to find some means to implement national plans. It's true for CPTS, where the framework is based on some known principles. Now, health professionals have to find appropriate organizations in the field. We have that some type of approach with hospitals. Public hospitals have to work together. This is expected, but they also have to build the appropriate channels, shared approaches, territorial teams, so as to be present, including in more complicated territories. I think we should be reasonably optimistic when we see the changes in the system over the last 20 years. The national level must remain at the in control. Now, you don't want to end up with a huge heterogeneity in the regions. We know that policies in our countries have been decentralized for the last 30 years, resulting in huge inequalities amongst the various regions. When you evaluate this after 30 years, you come to understand that if you want to change anything, you should not reproduce such mistakes. But the national instances have to define the requirements and the expectations. One last remark. We are in a country which has always been reluctant to evaluate things, but let's be reasonably optimistic about dynamic approaches. Article 51, how we promote alternative organizations with a clearly defined evaluation. This will help us to move away from regional intervention funds, which are great but do not suffice. Article 51, I'd like to come back on this. It's called Loi Buzyn, the Buzyn law. Some think it's a great opportunity for opening. Others, on the contrary, think it's too difficult and complicated as a scheme. What do you think about Article 51 in the light of your own experiences? Article 51 is great. It can be a genuine revolution so as to experiment things, new things that are not regulated yet, but it's got to move into the common law if it is efficient. It should not be left aside, unevaluated, not analyzed. This experiment has to be properly evaluated. I think that as with any case, any type of funding, it's difficult to comply with Article 51. And very little patient associations have the capacity to implement it. That's a shame because there are great ideas there, but we should have some type of support for smaller associations who work in the field with professionals, and they work remarkably. But if we don't go beyond that step of evaluation, and if we don't adapt this at national level, we will have spent a lot of money for nothing. I will not speak on Article 51 because this is not my area of specialty, but I think we should decluster health professionals. We should see what we are good at, where we should associate ourselves with other professionals. And I see some professionals here in this room. It really pleases me because these are going to invent tomorrow's medicines. They have expectations. They have objectives in terms of services to patients. It's not for me to declare what I think indispensable. I want to build with them on their experience so as to find new strategies. Yes, it's great to see many generations together.
Oui. Yes, Article 51, which is part of the financing law for the security system in France, it allows us to get beyond the regulatory framework problem in many areas, and that's very important. And we can see that the time, well, that's the risk with Article 51. It's the time, and there's an expectation that's not very easy to work on, given the time needed for assessment, to show that an alternative association really does offer something in terms of practices and efficiency. You need a long time. And with Article 51, it can be 4 years, but it can't be just 1 year or 18 months. And we can see the risk today. The risk, having worked with the national team coordinating the system, I'm familiar with it. There's an expectation from the field. There's an expectation among professionals. People, you know, who want to take over things that are validated in literature, but in our French context, it means that we've got to have the assessment before these things can be managed as a matter of routine for nutrition, for children, psychology for a certain number of patients, people with neuro-evolutive illnesses. There are a certain number of things that have been validated, that are being set up, but there are professionals and actions that are not covered by the health insurance system. So we need to draw lessons from the experiments being carried out, but we also need to take the time necessary to assess them. So we have the impression that they work, but we mustn't jump to conclusions. We mustn't, be too hasty about what we do. Yes, it's that risk that we've been familiar with, making systems, procedures widespread too quickly. It's very complicated in our country to take a step backwards and once something's been implemented. We're not pragmatic like the Anglo-Saxons. So, how far do we assess? And that's the question. We need to have a solid base, something that's consistent, that allows comparisons, but at the same time, we've got to have something that's very detailed. Yes, if in your region a patients' association has a project, something experimental, go and see the health agency. That's really our job. There are project managers who help professionals, who help freelance people. We've got 6 who have been assessed and validated in our region. The idea is really to provide support. I know that a freelance professional who is in the healthcare field doesn't necessarily have the time to draw up a 40-page specifications document. You know that in France, we're lucky to have these regional health agencies, but there are regional differences, let's say. And they're kind of dependent on people. Yes, we all understand that. So we'll go to the Burgundy region maybe. Anyway, coming back to the assessment, there are the assessment criteria that are important, but who sets the criteria? You can say, okay, it's been assessed, it's all well and good, it responds to the criteria, but the criteria may not be the right criteria for the people in that region, the professionals in that region. In terms of quality of life, for example, this is something that's rarely taken into account, and yet it's very popular, it's very important, and it's essential for patients suffering from rare diseases. I'd like to come back to the question of time. It really is an issue. Behind any kind of action, any kind of attempt relating to Article 51, you need professionals. You need professionals who say, okay, who say, okay, let's move on to something concrete. So we've got the 40 pages of Article 51 drawn up with the help of the regional health authority. But at the same time, the response times, you just can't imagine what they are. And healthcare professionals don't respond in that way. They just make a call and off they go. Well, perhaps not straight away, but it's much faster. So we're organizing a consultation campaign. I'm not questioning people, but we're currently setting up dynamic displays to promote prevention messages. So dynamic displays, televisions basically, in waiting rooms. Because we've realized, we found that flyers, well, they're not very efficient anymore. So yeah, it's more up to date to use something that's digital, that's right. So the health insurance system came to see us. They want to try out these dynamic displays as well. But I know it's taken 6 months. Now, of course, it has to go up to the management. It has to come back down to the bottom and loop the loop and what have you. It takes time. So I did my own loop. I did my videos, and it works. So if you like, that's the problem. You can't just start a subject and say, okay, we'll talk about it in 2 years' time. Healthcare professionals don't work like that. It's already difficult enough to get a buy-in because they're there, they're working, they've got time constraints, they've got agenda constraints. We all know this. So, getting them to work on projects that where we'll have answers or a response several months later, it's just not possible. So the timescales are not the same for doctors, for health agencies, for financiers, and for patients. That's how complex the situation is. Everybody has a different timescale. Everybody, and we need to, move forward at the right pace. So it's very difficult to implement. So Article 51, for me, it looks good on paper because we're talking about waivers, exceptions, so that things can be accelerated, so that innovation can be facilitated. So that can only be good, can't it? However, then you have the question of putting all of that into practice, and that's where the problem lies. The administrative procedures are heavy going. There's the question of assessment. There's the question of the criteria that have to be defined. Coming back to the assessment, we've already talked about it a lot, but I have an example from Spain. Assessments are carried out at autonomous community level. That seems good, doesn't it? But there are so many disparities between the different assessments that in Spain there is a kind of imbalance now, an inequality, if you like, when it comes to the patients, when it comes to the access to care, because the assessments are so different from one autonomous community to the next. So, of course, we need more flexibility. There are too many different echelons. That it's all too heavy going. It's too complex. We need to trust our healthcare professionals more. We need to get people to work together more, and we need to have that relationship of trust. So, and we have less cogs in the wheel, but we don't want the opposite either. So, Article 51 should be a very good thing. But you know, hearing healthcare professionals and what they say, I've realized that, you know, there is still a lot of questions out there. So let's go back to what you were saying. You were talking about the jobs. Now, I agree with your opinion. You said that one of the best ways of managing healthcare areas was not to make new jobs, but to reorganize those jobs. And this brings back to what Guy Valencien was saying. You talked about teams, so doctor, nurse teams, two professionals working together, but differently. Maybe I won't talk about Germany. The system is interesting there. They're very much focused on hospital stays, and that can be disastrous. Now, clearly, you study for 10 years to become a doctor. You become an expert. The patient comes to see you and comes to see your expertise. You've got to respect the specifications, the medical time, and the expertise. And since patients don't have that much time with the doctor, there are other professionals that can also come, not as supporting systems, but as collaborators, as partners, you know, to ask about whether there have been any additional problems, for example. And that's where we would have added value. And it's essential. I'm sorry, I'm going to go beyond your question. There are initiatives. I have some stories that I can tell you. The private sector wants to invest in Europe in prevention actions. This was presented by the European Commission this morning. It's a major challenge if we want to optimize our overall systemic performance. And it's very important to do that. So we could talk about prevention then. It's a very important challenge for any area, any health area in France. What would you like to say about that? Yes, I'd like to talk about the new jobs. So we've been talking about nurses who can manage, take over medical acts, or pharmacists. But what about expert patients? Patients now have expertise, as we know. There are even universities of patients so that they can become more professional. So this is a resource that hasn't been used very much in the healthcare system. Now, of course, we need to be able to actually professionalize them. Each job has to have a salary. There are expert patients in associations that already work well. But the problem is, Eric Salah will be talking about that in another round table. When you've got 30 or 40 students who have come out of the patients' university with their diplomas, how many of these are actually taken on, recruited, because there are obstacles out there in the field? People don't want to get patients involved in hospitals. They don't want to pay them. But let's not forget that the patient has a certain amount of expertise, especially when it comes to chronic diseases. Patients can use their expertise to relieve the healthcare system, and we forget about that too quickly. So let's go back to prevention. Now, beyond prevention, there's the reorganization of how professionals are deployed when it comes to chronic diseases. We can see that things are changing. Let me remind you of the Azalea nurses. You know, it's an experience that takes us back 15 years. It shows us that there are still professional obstacles. Our healthcare system is based on specialized medicine and hospitals and individual practices. So we need to focus more on care and ambulatory care. The three pillars after the war have been undermined by a complete shift in paradigm. And this includes the professionals. I think that, health innovations, we've got health innovations, we've got experiments, and these will allow us to move forward, to move ahead. We have these expert patients. We've got a project in our region for diabetic patients, where patients are in the front line when it comes to coaching and providing support to people who are overweight. And it's all part of telemedicine as well. But, we mustn't frighten people either. We must, use a trial and error approach. But I hope that this will work. It's about redistributing roles, sharing roles between doctors and other healthcare professionals and patients. In November, in Paris, we're going to be talking about how to complete evidence-based medicine with the know-how of patients and human sciences, and how we can use these skills to improve quality of life. I think we're at a turning point when it comes to the way we consider the healthcare system. We could have spent a whole day and a half on this subject. I think everybody agrees. Coming back to prevention, yes, there's a great experience in Milan, in a hospital in the Garibaldi area where there's a station. There's a unit with a nutritionist, a chef. So there's a unit set up where people come and learn more about nutrition and diet, and it's in Milan. Yes, I want to just come back to a point. All of these projects, all of these changes to medicine in France, to the healthcare system rather in France, require inter-knowledge, knowing each other. In healthcare centers, for example, there's this inter-knowledge, coordinated actions. And I think it's as part of that framework that such projects can emerge. I had a last question for each of you. Do you have a simple, realistic idea to improve the coherence of our healthcare system at area level? An idea that doesn't exist today. The link with the hospital. What do you mean? In other words, once again, we need to learn to know each other. We need to learn to work together. And of course, include the patient in that. But make sure that there's no break along the patient's path. Assessments. Yes, that assessments are fundamental. What's your position? Well, I'm perhaps going to make people cross. Well, we're here to debate. I want the public health care law. Now, might cover 100 pages. You're saying about being realistic, and I'm not being realistic. If our country cannot be reformed in depth in the healthcare sector, among other sectors, well, it's a very serious situation. Very short. I don't know whether it's realistic, but it's a very strong idea. We need to remunerate professionals' activities, not according to their activities, but on service rendered. Yes, well done. Now, I have 20 seconds. I have 20 seconds just to suggest that we work with and not for patients. Thank you. So we've said many, many things. We didn't talk about financing, but I'd like to thank all of you. We've got 7 seconds just to say thank you to all of you. Thank you very much.